Welcome to this video on diabetes mellitus classification. We understood the pathophysiology of type 2 diabetes, and now let's understand the classification of diabetes mellitus. So, if you see Harrison's Internal Medicine, the latest edition, and American Diabetes Association Standards of Care 2024, and RSSDI, its Research Society for Study of Diabetes in India, all three, the classification given in all the three is almost same. Like I would say Harrison and this one ADA is, they are all, like 100% same, and RSSDI I would say 80 to 90% the classification is same. So in the previous days when we didn't know much about diabetes, we thought that there are only two types of diabetes, type 1 and type 2. Now with extensive study we have got to know, apart from insulin resistance and insulin deficiency, we have got to know other pathogenesis also, and that is why now we have more than two types of diabetes. In this video let's learn what are those things. So first, what is diabetes? Diabetes is a group of diseases that share a feature of hyperglycemia. There are various types of diabetes, and the common thing about these is they have hyperglycemia, like raised glucose levels. Then classification of diabetes. The first classification is, you all know, the type 1 diabetes. Here what happens, there are autoantibodies against the pancreatic beta cells. So these antibodies destroy the pancreatic beta cells. And because pancreatic beta cells are destroyed, there is insulin deficiency. If you see my video of pathophysiology of type 2 diabetes mellitus, I have told like how C-peptide is actually a surrogate marker for insulin. So in brief, C-peptide actually, whenever insulin is produced in the body, C-peptide is also produced. So if the body is producing enough amount of insulin, there are enough amount of C-peptide. And same thing goes, like if the body is producing less amount of insulin, there are low levels of C-peptide. Because in type 1, the insulin level, the body is not able to produce sufficient insulin, the C-peptide levels are low. And this type 1 is commonly seen in younger individuals. Then second is the commonest one which we see, the type 2 diabetes mellitus. So even in that video, pathophysiology of type 2 diabetes mellitus, I have told you how it initially starts with obesity. Obesity actually increases the insulin resistance, and then what happens, there is hyperglycemia. There is a vicious cycle, then finally there is a beta cell failure leading to insulin deficiency. So type 2 starts as insulin resistance and progresses to insulin deficiency. How it actually happens, I have told this in detail in that video, pathophysiology of type 2 diabetes mellitus. So this is relatively at a later age of onset. So the type 1, type 2, and next we'll see what else, what new has been added in the classification. So third is a specific type of diabetes. We know that insulin is produced by pancreas. Any condition that will damage the pancreas will reduce the insulin secretion also. For example, like pancreatitis, especially the chronic pancreatitis. There is an operation where the pancreas has been removed, pancreatectomy. Even in these cases, there is hyperglycemia. Cystic fibrosis. Cystic fibrosis affects lung, liver, and pancreas. So whenever pancreas is affected, insulin secretion is reduced, and therefore the patient will have raised glucose levels. It can also happen in hemochromatosis. Apart from that, any endocrine problems can also cause raised sugar levels. Insulin is the only hormone which will reduce the blood glucose levels. But other hormones, all other hormones will actually work in increasing the sugar levels, like growth hormone, thyroid hormone, corticosteroids, glucagon. Glucagon is one important hormone which increases the glucose levels, and aldosterone. So any excess of these hormones will also increase the glucose levels. So acromegaly, hyperthyroidism, Cushing's, glucagonoma, aldosteronoma, all these will raise the blood sugar levels. Drug-induced glucocorticoids can increase sugar levels. Beta agonists, thiazide, there are many other medications, but for the day-to-day care, these are the important. Glucocorticoids can raise blood sugar levels, beta agonists can raise, and thiazide diuretics. So this is the specific type of diabetes, either due to pancreatic insufficiency or other endocrine cause or drug induced. Then fourth is the gestational diabetes mellitus. What happens in pregnancy is there is increased estrogen, increased progesterone, then there is leptin, cortisol, human placental lactogen, and placental growth hormone. These hormones are increased and they develop a state of insulin resistance. Because of these hormones, there is insulin resistance, and therefore the pregnant women are at a higher risk of developing diabetes. So in the gestational diabetes mellitus, the hyperglycemia is detected during the second and the third trimester. You say it as GDM only when it is detected in second or third trimester. What happens if you see hyperglycemia in the first trimester? It is most likely to be exaggerated. Like there is a pre-existing hyperglycemia, but it got exaggerated during pregnancy. It's not a pure GDM. Harrison says it as, if there is any hyperglycemia detected in the first trimester, before that the patient did not know, this is actually a pre-existing pre-gestational diabetes mellitus. Okay. 16 to 20% of the patients have pre-existing diabetes mellitus, or they eventually develop gestational diabetes mellitus. So once there is delivery, or once the pregnancy is discontinued or terminated, the sugar levels will come back to normal. But why is this very important is, in future 30 to 60% of the patients will have a risk of developing diabetes. Okay, so we had four types. Type 1, due to autoimmune antibodies destroying the beta cells of the pancreas, and there is insulin deficiency. Type 2, it started as insulin resistance, but with vicious cycle it became insulin deficiency. Type 3 are the specific. It can be due to reduced pancreatic function, removal of pancreas, endocrine causes, or any medications. Next is the gestational diabetes mellitus. Okay, so this is a newer type, maturity onset diabetes in young. I wouldn't classify this. This is a newer entity, and currently it's not under any classification. So what happened? There were two physicians. They are very, very well-known physicians. They are like Robert and Stephen. They were actually studying about the diabetes. They came across few younger individuals. There were younger individuals who had hyperglycemia. Less than 25 years of age, they had hyperglycemia. Okay. Normally, what do you think if young patient is having high sugar levels? What do you think? Type 1, right? Even they thought the same thing, and they checked for the antibodies. But to their surprise, the autoantibodies were not present, they were absent. Then they were checking is there any insulin deficiency? To their surprise, the insulin levels were also normal. The C-peptide levels were normal. There were no autoantibodies. So it's a case where younger patients are developing diabetes, but it is not due to autoimmunity or the autoantibodies. There is some other reason. And there was one more very striking feature about these things is, see, normally what happens in our family, right? Our parents might be diabetic, but having diabetes in our grandparents or great grandparents is very rare. Our grandparents, grandfathers, or great grandfathers wouldn't have had diabetes. But in these families, diabetes was a well-known thing. Their fathers would have, grandfathers would have, at least 3 or more generation. Diabetes wasn't a new thing for them, and it was inherited in autosomal dominant pattern. So then they were thinking, there is a genetic problem which actually gives rise to hyperglycemia, diabetes. And one more striking feature was they do not usually present with ketosis. So it's incidentally detected. Okay, this is the best thing. They have good response because the C-peptide levels are normal. It means that there is no insulin deficiency. There is some other problem. there is good response to oral anti-diabetic agents. This is very important about MODY. See, why do you have to keep in mind whenever you're treating a patient with type 1? Because see, type 1 treatment is insulin, right? They'll have to inject insulin. But if you have a suspicion that this is not type 1, this might be maturity onset diabetes in young, you can ease their life by giving oral anti-diabetic agents. And then they ought to know, okay, there is a, see, this is called as monogenic diabetes. Why is this called as monogenic diabetes? The reason is, normally type 1 or type 2, we call it as multipolygenic in nature. For example, there should be some component of genes, there should be some component, some impairment in the lifestyle, some impairment in the genes. Only then these diabetes 1 occur, like diabetes mellitus occurs. But these set of genes do not need multiple factors. One gene is impaired and done. They develop diabetes. That is why this is called as monogenic diabetes. And what are the common genes? So this is not very important. Like you can just keep hepatocyte nuclear transcription factor 1 alpha, hepatocyte nuclear transcription factor 1 beta, 4 alpha, genes encoding glucokinase, insulin promoter factor, ATP sensitive potassium channels, and mitochondrial DNA. There are around 14 types of MODY. Okay, and these are the important genes that are affected. You don't have to know, but you should know when you should suspect maturity onset diabetes in young and not type 1. Is this clear? Once you suspect, if the patient is can pay for it, there are very less laboratories that will actually do genetic testing for MODY. Like it is done in CMC Vellore, it is done in Madras Diabetes Research Foundation. There is a lab called a MedGenome lab in Bangalore. They do the genetic testing for MODY, but otherwise it's very, very less. You normally you don't need to do it, but if the patient insists, for example, like these days, patients will always ask, what is the cause of this? If patients can pay and they can insist, you can send for genetic analysis. It will be anywhere in a patient, like if you suspect 100 patients with MODY, maybe around anywhere between 15 to 20% will have genetic mutations, any of these. So is this clear? A young patient coming with hyperglycemia, keep two differentials in mind: type 1 diabetes mellitus first, followed by maturity onset diabetes in young. Now this is very, very important table. You will have to differentiate. The main differentiating factor will be the autoantibodies. Autoantibodies are absent in MODY, and in type 1 they are present. Also C-peptide levels. C-peptide levels are reduced and they are normal in MODY. Then family history. Family history is always positive in MODY. Why? Because they have autosomal dominant pattern of inheritance. That is why it's always positive. In type 1, it can be positive or negative. Then presenting with ketosis. If there is a younger patient coming with ketosis, think of type 1 first, because ketosis is very, 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 very rare in MODY. Response to oral hypoglycemic agents. So if you are suspecting MODY, what you can do is you can give them a trial of oral hypoglycemic agent. Like first evaluate, antibodies are negative, insulin levels are normal, you are suspecting MODY, give a short trial of oral hypoglycemics and see how they are responding. If they are responding well, it's very, very likely that it's a MODY. Okay. So this table, like differentiating between, you don't have to differentiating between MODY and type 2 because the age is slightly different. But sometimes when you come across, you can use this. Age less than 25, age will be the very important differentiating factor here. So less than 25 is MODY. More than 40 years, you should keep type 2 diabetes in mind. Then weight. Weight is normal in MODY. If there is obese patient, the patient has acanthosis nigricans, then it's likely to be type 2 rather than MODY. But if the patient is lean, there is no acanthosis nigricans, then it's likely to be MODY. Okay, then to confirm it, you can just get the insulin levels done. So insulin levels, type 2 is a state of insulin resistance. What is insulin resistance? Means normal amount of, they will need higher amount of insulin for the same action. The insulin levels will be raised in type 2, whereas it will be normal in MODY. Okay. Now next, atypical. There are few diabetes which share, like, which is a mix of type 1 and type 2. They have few features of type 1, they have few features of type 2. We call them as type 1.5 diabetes. Okay. One of the important type 1.5 diabetes is latent autoimmune diabetes in adults, that is LADA. So LADA is the opposite of MODY. Okay, MODY was antibody negative in younger individuals. LADA is antibody positive in elders. So this is antibody positive in elderly. This is LADA. Ketosis prone diabetes, that will be dealt separately in different video. Here I'll be discussing only about LADA. So next, this is associated with autoantibodies, the same autoantibodies. It is seen in 30 years is the cutoff. The patient should be minimum 30 years of age. It is seen in elderly individuals, the autoantibodies are present. See, if a patient is coming maybe 40 or 50 years of age, the patient is coming with diabetes. Normally we think that it's a type 2 diabetes, right? But what happens is you start them on oral antidiabetic agents. The response to oral antidiabetic agents will be very poor. And then you will have to shift them to insulin. In such cases, you should actually keep LADA also in mind. Maybe like if you get their antibodies done, it might become positive. I'll give you an example of a patient. So there was a patient of mine where the patient was in mid 50s, like 55 or something, and he was diagnosed with diabetes. The patient was initially like 55 years of age, there are high sugar levels. We thought it as type 2 diabetes mellitus, and we started him on oral glycemic agent, like oral anti-diabetic agents. What happened, like with time, his sugar levels were worsening only. Like even though we were trying to increase the dose, changing the medication, adding the medication, the sugar levels were not actually getting controlled, and we had to shift him on insulin. Like initially his wife would say, ma'am, my husband doesn't, follow strict diet, he smokes, he drinks, therefore that is the reason his sugars are not getting controlled. We also actually got carried away with it. Then after, when we started him on insulin, he was actually requiring more amount of insulin for his weight. That is when we thought, okay, let us actually check if he has antibodies or not. And to the surprise, he had positive for antibodies. That is when we got to know that it's a LADA, latent autoimmune diabetes in adults. Okay. So this is associated with antibodies. It is seen in elderly individuals more than 30 years of age. Initially controlled with oral antidiabetics, but they will need insulin supplementation in the later course. Okay, this is important. So elderly patient having diabetes, there are two main differentials. One is the LADA and another is the type 2 diabetes mellitus. So first is the age. For LADA, the patient should be minimum 30 years of age. Type 2 is relatively at a later age of onset, like maybe after 40 years of age. The main thing will be to check the antibodies. Okay, antibodies are present in LADA. It's absent in type 2 diabetes mellitus. Insulin requirement, initially it's low and then it's drastically high. In type 2, like it's low. If you see an obese patient having acanthosis nigricans, think of type 2 diabetes mellitus. If you see elderly patient who is normal, lean, who doesn't have acanthosis nigricans, okay, and even though he's lean, he doesn't have signs of insulin resistance, but still he's requiring insulin, in that time think of LADA. Okay. So now we know the types. For a quick recall, we'll see type 1. Okay, type 1, younger individuals, autoantibodies, and low C-peptide levels. Type 2, insulin resistance will progress to insulin deficiency. It is seen mainly in obese, and they'll have signs of insulin resistance like acanthosis nigricans. Then gestational diabetes mellitus seen in second or third trimester. Why it happens? Because due to increase in the estrogen, progesterone, human placental lactogen, several pregnancy hormones. These hormones induce insulin resistance and there is hyperglycemia. Then what is MODY? Maturity onset diabetes in young. So young people have diabetes but the antibodies are negative. They have a positive family history, like in more than 3 generations are positive for diabetes, and more than 3 generations have diabetes, they are less prone for ketosis. This is the main thing. Then coming to LADA, latent autoimmune diabetes, it is the opposite of MODY, means antibody positive diabetes in elderly. Okay, so with this, let's diagnose few cases. So here is a 61-year-old grandpa with HbA1c of 8. Anything more than or equal to 6.5, we consider it as diabetes. So this grandpa is diabetic. Okay, let's see what can be the differentials for this. So elderly grandpa, it can be type 2 or it can be LADA. Okay, now let's see further details. Mother had a history of type 2 diabetes mellitus. Okay, so it still can be type 2. BMI is fairly okay, borderline, and there is no acanthosis nigricans. This history is not very sufficient to rule out any of these two differentials. Let's see next. So let's try few shots of oral hypoglycemic agents and see. Imagine that we started the patient on metformin and glimepiride. Okay. So after 3 months, the HbA1c is still 10. Initially it was 8 and now it has progressed to 10%. So now what do you think? You think more in terms of LADA. So now this is the very good clincher. C-peptide levels are low. It means that insulin is low. Then autoantibodies are positive. It means that there is autoimmunity. So this will be a definitely case of what? LADA, latent autoimmune diabetes in adults. Now, second case. There is a 30-year-old lady who is having fasting blood sugar level of 150. So 150 is definitely high. What can be differentials for her? She is a young patient, right? Young patient can be type 1 diabetes mellitus. Can it be type 2? Yes. Asians have a high tendency, like the age of onset of diabetes in Asians is high, like at a younger age. So we can keep type 2 diabetes also in mind. And since she is 30, we can also keep MODY in mind. We have 3 differentials for this patient. Type 1 diabetes mellitus, type 2 diabetes mellitus, and maturity onset diabetes in young. Now let's see further history. Family history is not significant. So now what can you rule out? For which condition you must have family history? For MODY, right? Because here the pattern is autosomal dominant. Now because there is no family history, MODY is ruled out. We just have type 1 or type 2. BMI is high, okay? And acanthosis nigricans is present. So what is the likely cause? It is more likely to be type 2. But still, obesity is very common in India. Right? That is why we still have to rule out type 1. Now let's see. Okay. Now this is the clincher. Autoantibodies are negative and fasting C-peptide. Is this normal or low or high? 1200 picomoles. This is high. So normal fasting C-peptide level is somewhere between 300 to 1000. This is normal. Normal is 300 to 1000 picomole per liter. So this is normal. The fasting levels are definitely high. and there is no autoantibodies, this means that this is a case of type 2 diabetes mellitus. Is this clear? Now, case 3. A 20-year-old boy had random sugar levels of 336. It's very high. Okay. Now, what can be a differential? So, young patient having diabetes, first will be type 1, next will be MODY. Okay. Now, let's see further details. Positive. Okay, there is a strong positive family history. The disease is positive in father, grandmother. BMI is fair, like the boy is lean only. And acanthosis nigricans is absent. So now what are you thinking? You're thinking it. This is actually not, because in type 1 also there is like type 1. We are actually differentiating between type 1 and MODY, right? So BMI and acanthosis nigricans are like, they do. Both of these will not have signs of insulin resistance. But positive family history, like 2 generations have, this is looking more like MODY. Now let's see. Laboratory investigations. Okay, now this is the clincher. For young patients, always perform antibodies and perform C-peptide levels. That will help you differentiate type 1, type 2 and MODY. So autoantibodies are negative, fasting C-peptides are normal. This means that there is no autoimmunity. A young patient having high sugar levels, but there is no autoantibodies and insulin levels are normal. Also, this patient was asymptomatic and high sugar levels were discovered during the routine examination. All these points towards what? Maturity onset diabetes in young, MODY. Okay. Last case. Let's look at the last case. Okay. A 10-year-old child is brought to the casualty with abdominal pain and shortness of breath. So the a young patient is presenting with decay. Here only you should be able to diagnose. This will be type 1. Okay. Young child presenting with decay. The sugar levels are 525 mg per deciliter. Okay. Let's see. Young patient, same differential. It can be type 1 diabetes or it can be MODY. But MODY patients, they do not come with ketosis. Okay, the ketosis is very rare in MODY. Therefore, like I assume it to be type 1. But let's see the further details. So family history, there is a type 2 diabetes mellitus in father. A 10-year-old child having type 2 diabetes mellitus is very unlikely. BMI is also okay. So this is also, the examination is also not favoring type 2. Lab investigation. Now this is the, so anti-glutamic acid decarboxylase is positive. Anti-GAD antibodies are present and C-peptide levels are low. It means that it's a type 1 diabetes mellitus. Okay, so this was about the classification and we solved few cases. Just for your recap, that is it from my side. I would like to hear your feedbacks and what further things you want to learn. Thank you.